B. The mitral and the tricuspid valves occur together. That's why we hear only one sound. It's called S1, the first sound, by our definition. And then when they relax, you hear the pulmonic and the aortic valves making their noise, and that's the second sound. There are cases where the sounds can be split. Normally, they close exactly together. You're really hearing mostly the mitral sound. It overcomes and obscures the tricuspid sound because of pressure. Same thing in the pulmonic and aortic. You're hearing mostly aortic because it's a higher pressure system. But suppose there's something that makes them split. Suppose, for example, there is mitral stenosis. The mitral valve may take longer to open. Or there's a conduction defect making this open later. Then you might hear bup-bup-bup, bup-bup-bup, bup-bup-bup. You're going to hear the two valves, the mitral and the tricuspid valve, splitting their sound. That's called a split first sound. Or the same thing could happen if there's aortic stenosis. You might hear the normal mitral valve, bup, 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 bup. That's a split second sound. And you can split all four valves, and you can hear bup, 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 bup. And you can make the diagnosis just with a stethoscope. Or 100 years ago, just putting your ear to the chest of the patient and listening. It's not very sophisticated, but it actually works. Now, what can happen, there are lots of diseases that can make this happen, and there are things called gallop rhythms. Often one pair of valves is okay, the other pair of valves is not, and you'll hear bup 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 bup, or you'll hear bup 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 bup, depending on which is split, and we call them Kentucky and Tennessee gallops, because it sounds like somebody's going Kentucky, 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 or Tennessee, Tennessee, Tennessee. And the pairing of those gallops tells you what's going wrong. Different pathology, different problems with the valves cause different gallop rhythms. We also have murmurs. That's another sound you've probably heard about. If your valve isn't opening well, it's going to cause turbulent flow on the way out, not just when the valve's closed. So during systole, ventricular systole, what you may hear, for example, in aortic stenosis, a tight aortic valve, is psh, bup, psh, bup. The first sound will be obscured by the murmur, which starts immediately with the opening, and you'll hear psh, bup, psh, bup. Or if you hear mitral insufficiency, you might get a similar murmur at the same time, different pitch. And you can have murmurs all over the spectrum depending on where they're happening. They're called systolic murmurs, diastolic murmurs, and we hear them in different places. We actually don't hear them exactly where the valves are located. If we look at this diagram of the placement of the valves and the placement of the sounds, here are where the valves are actually located. Remember from our other picture, here's the aortic valve with the blood going out this way. Here's the pulmonic valve, blood going out this way. Here's the bicuspid or mitral valve, and here's the tricuspid valve. First of all, we don't like to listen right over the sternum. That's bone. It's in the way. We like to listen in the interspaces between the ribs where we can hear things better. And we place our stethoscope way up here where the blood is shooting out in this direction. We put our stethoscope over the area where we're going to hear the turbulence, and we hear it best. And that allows us to make the diagnosis and sometimes even separate the sounds. For example, we can hear the mitral valve here very well. Anywhere else it'll obscure the tricuspid valve, but not here. Here we'll hear the tricuspid valve better. So we can make our diagnosis that way by knowing where we place the stethoscope and by getting an idea of what's going on with those valves. What can we do for these patients? Occasionally we can do some things to help them out. If they have some of the problems we've talked about, very quickly we can put a balloon into the coronary vessels. We can blow that balloon up, and we can squeeze the plaque shut, get the obstruction open. That's a coronary angioplasty, done without putting the patient to sleep, just through a vessel in the arm or leg. Today, we can put in stents, which are little wires that hold these open so they don't close. And now, in the further improvement, we actually have chemicals that seep off these stents to make the repair better and keep inflammation from occurring. And finally, we can do bypass grafts where we jump right off the aorta with an artificial graft, either a vein or a woven dacron, and go past an area of obstruction into the coronary vessels. This is all very aggressive, very scientific and technically difficult surgery. Some of it's actually rather easy, easier than you would suspect. But we do give patients a much better lease on certainly their activity, if not their longevity. And these procedures have become less invasive with time. As I said, the coronary bypass surgery is an open chest operation done on bypass pumps, which is a very, very big deal, as opposed to percutaneous, meaning going through the skin, into vessel, transluminal angioplasty, and placement of stents. This has been a remarkable improvement.